Les doy la bienvenida a este nuevo webinar de Fundahigado América. En esta oportunidad vamos a compartir con nuestra audiencia el tema de las medicinas que utilizan nuestros pacientes trasplantados. Muy específicamente en relación al tema de los inmunosupresores, así como a otro grupo de drogas que son conocidos como drogas profilácticas que se usan también durante el momento de trasplante. En esta oportunidad tenemos la grata compañía de la doctora mía Schmiedeskamp-Rahe, que es directora del PJY2 de la residencia de farmacia de trasplante de órganos sólidos y es profesora asistente de la Universidad de Illinois en Chicago. Junto con ella nos va a estar también acompañando el farmacólogo David Choi. David Choi es profesor asistente del departamento de farmacia de la misma universidad. Y con ellos vamos a compartir una conversación que esperamos que les sea de utilidad a todos ustedes.
Thank you so much for joining us. This is part of what Fundahigado America does for the region. We work on an idea that every child in the region should have the option to receive a timely liver transplant. So one thing that a lot of parents they don't understand is that when they have, let's say, a child with biliary atresia, you know, they go from cholangitis, they go from ascites, they bleed. So they get a lot of medication. So after the transplant, they have to understand that they're just going to switch from one medication to another. So that's very important. So why don't we start talking about what is an immunosuppressant?
Yeah, I think that's a really great question. So immunosuppressants is just a fancy word for anti-rejection. So essentially our bodies are designed to fight off things that are considered foreign. So when we get an infection, that could be bacterial, viral, fungal, anything along those lines, our bodies are designed to fight those off as much as possible. It's like our natural immunity, our natural body's defense against it. With the transplant, we're doing the same thing. We're taking someone's liver and then placing it inside of the recipient. And as a result, there's a chance that the body will see that as foreign and they want to fight it off. So we have these medications that we call immunosuppressants or anti-rejection, and they're really kind of built to help calm down the immune system so that the body doesn't fight off the new liver.
Some parents will ask maybe, David, how long do they need to take the immunosuppressant? It's just going to be a week, it's going to be a month, or it's going to be a lifetime?
That's a great question as well, and we're going to go into a little bit more about the different types of immunosuppressants, but in general we actually will consider lifelong immunosuppressant because there's always a chance your body's going to try to fight it off. Especially at the beginning it may be more, but over time we're going to start dropping the doses, decreasing the goals, and decreasing the number of immunosuppressants.
Okay, so that's very important. So they need that kind of medication that they need it for life. So I know that parents will also face the fact that there are many immunosuppressors nowadays. So why don't we talk about the most common?
Yeah, so I wanted to talk a little bit about the main ones that we use in children. We have, as David said, a lot of drugs these days that can suppress the immune system, and this is so helpful for transplant because, of course, we want to protect the new liver from the immune system. And often children start out on maybe 2 or even 3 of these drugs, and as David said, over the months and the years, the goal will always be to try to reduce that. And so by several years out, many children are still only on one drug, and at some point we sometimes even go to once-a-day dosing. So I think the first thing to know is, even though I'm going to say a lot of names, often the regimens that we have these people on do get simpler over the years, so don't be scared by it. Some of the common names that we have that you might come across are tacrolimus and mycophenolate. And then you're probably at some point going to come across some steroids. Probably the most common one is prednisone.
Mia, let me just ask you something before we get into that, and I'll just show you a couple of examples because it's going to happen in the region. You can see this is a box of Prograf, but this is a different box of Prograf. So some people might get confused. Well, why am I getting the blue box or the white box? It comes to the fact that we need to talk at some points about generic. So
Could you mention a little bit about the fact that some are the mother drug and the other ones are generics?
Yeah, I have to say that as a pharmacist, this is one of the things that I find most frustrating, is that drug companies find a need to give drugs different names, and some of these drugs have multiple different names. And so when I think of a drug as a pharmacist, often I try to think of the drug that the scientists originally invented. And for example, tacrolimus is a very common name of a very popular drug we use, and that's the way that it was first named. Drug companies may give it other names. For example, the box that you held up called Prograf is a name that was picked by a drug company for their version of tacrolimus. But sometimes you may just get we call it a generic. You may just get the pill that is just labeled tacrolimus. Yes. If you have questions, ask your pharmacist or ask your doctor at your transplant center. Exactly. Because you may be looking in a box that says tacrolimus, you may be looking at a box that says Prograf, and then the little trick is that some of them are given differently. So that first box you held up has to be given twice a day, but that second box you held up has to be given once a day. This is something that you would, of course, not know as a parent, but you know who can help you with that is your transplant center.
Yeah, so I just wanted to kind of just mention very briefly, so the families will address either the pharmacist or the physician itself, because it might happen. So it's just so we just drop that in the picture. Okay, so why don't we just talk about tacrolimus, which is a drug that is our basically mostly used drugs. So why don't we talk about how do we use it, how do the child will take it, and the usual doses, and maybe some small information about side effects that we need to be in the lookout for.
Yeah, absolutely. So I'd be happy to start off with the tacrolimus. So this is a twice-a-day medicine, and the thing that's really special about this medicine is we can measure exactly how your body responds to it. So we check it in the blood to see exactly how much tacrolimus is in there. So because of that, we can change the dose quite frequently just to make sure that we're hitting a certain goal. So what I mean by that is there's a certain range of tacrolimus we're going to aim for. Not too low, not too high, right in the middle, almost like the Goldilocks sweet spot that we're going to aim for. So especially at the beginning, we may ask you to do labs twice a week, and that's to make sure the liver, the kidney, everything's looking okay, but in particular that the tacrolimus level is looking okay too. We're going to call you and say change your dose to this, change your dose to this, because we're trying to get you into that perfect range in terms of the level.
Okay, let me just jump in, and so people understand that means that you might have a dosage that you recommend, but it will vary by body weight, and it will also vary by the way that the child is metabolizing the drug. So what matters is the blood level itself, and of course the labs, how they're working.
Yep, absolutely. And I think that's a great clarification. It's those labs. So the dose may kind of vary after as well.
And what about some side effects that we might encounter with these drugs that the parents needs to be in the look for?
Yeah, absolutely. So there are some physical side effects that can happen with tacrolimus. Some of them are level dependent. So when the levels get a little high, sometimes kids or the recipients can get a little shakiness called tremors. They can get headache as well, and those are things that we know can happen with the tacrolimus. So those are questions that at the transplant center we'll always be asking: are you having any shakiness? Are you having any headaches? Some of the other things that can happen is, especially in the blood, is electrolytes. The electrolytes can change a little bit with this medicine, so it's something that we're always going to be checking, especially with those twice-a-week labs that may become once a week and every 2 weeks and the monthly and so forth. We're always going to be screening for these electrolytes just to make sure they look okay. Especially with long-term use of tacrolimus, especially over long periods of time, there is a chance for kidney damage as well as new diabetes and high blood pressure. So those are things that we know can happen, and as a result, we're screening for well in advance, and we're looking for these things. And when they do happen, we have strategies to kind of help and kind of come up with a plan afterward.
Okay, that's a great point that I want to stress out, because sometimes the child was not a diabetic before the transplant and might need some hypoglycemic drugs by mouth or even some insulin if it gets worse, or the child was not hypertensive and now it became hypertensive. So this is part of the story that the parents have to be informed that we need the immunosuppressant drugs because of the reason you explained at the beginning, but there's some side effects there. But overall, I think we could agree that tacrolimus is a great drug that we have now available to help the results. So some trials will be in double therapy or triple therapy. So usually the double therapy includes mycophenolates. So why don't we talk about that other drug?
Yeah, I'd be happy to talk about this one as well. So mycophenolate also generally tends to be a twice-a-day medicine. Unlike tacrolimus, it's not something we always will check in the blood. So a lot of times it tends to be a weight-based dose that can kind of change over time. So the biggest side effects with the mycophenolate are two ones. The first one is sometimes people can get some upset stomach. So what that means is sometimes you can get nausea, vomiting, diarrhea. At the transplant center, that's questions we'll always ask. So if a child receives this medicine and gets nausea, vomiting, diarrhea, really important to let the team know because we have strategies to help, which we can spread out the dose, decrease the dose, change formulations, and things along those lines. The other side effect that can happen with the mycophenolate is it can make the blood counts go down. So those are things with those twice-a-week labs, weekly labs, things along those lines we're always be on the lookout for, and we have strategies to help with that if they were to occur.
Yeah, and I want to jump into, you have mentioned several times about the lab work. So this is why it's so important that the patients go to the clinic after the transplant and they have their lab run correctly, so you guys or us, the liver transplant surgeons, can make the right decision in order to avoid any side effects or in order to treat some side effects, because sometimes we cannot avoid it, but we can certainly treat them. But identifying them early, I think it's a key point, and that's important that they are informed. So then we have the all steroids, which is part of the triple therapy that they're always around, and giving steroids to a 2-year-old is a whole story. So why don't we just talk about steroids as well?
Yeah, so I wanted to talk about steroids a little bit. When I think about steroids, I think of them as incredibly valuable because they're very strong at preventing rejection. And certainly, some children do need them for a long time, people with autoimmune disorders perhaps, or a long history of rejection. But when I think about steroids, I also think about them as having a side effect burden. Any patient on them, adult or child, you have to consider in the back of your mind the potential for infections or diabetes or hypertension, which is high blood pressure. For children, though, I add to that list some worries about children who have a large exposure or a long exposure to steroids, thinking about their bone health and their risk for fractures, and then also whether they're going to reach their expected growth on time. So I definitely have a mixed view of steroids, but many centers use them at the beginning of the child's course after transplant, and then most centers work very diligently to try to reduce the exposure to steroids as the months go on. For example, at our children's hospital here, around month 3, they start reducing the steroids, and within the first year, most children are able to become off of them.
So we have pretty much covered the most used immunosuppressants. We'll maybe leave for another program the mTORs and all the inductions and maybe the treatment of rejection, so the parents can understand that sometimes we need to get them boluses, so they need to get some IV drugs. We'll maybe leave that for another later time. But sometimes the parents will bump into drugs like this. You know that as a Valsite or Diflucan. So these are another set of drugs that are not completely immunosuppressants, but it's something that will explain that they are prophylaxis drugs. So why don't we talk about a little bit about prophylaxis? Because David mentioned a little bit about the different types of infections when he was talking about the effect of immunosuppressants, and I think not that in a way comes into place. So why do we use prophylaxis, and what are the most common drugs that the parents will get acquainted with?
Yeah, so we always use infection prophylaxis in our patients, whether they're children or whether they're adults. And it's honestly just because we have to give them these immunosuppressing drugs to protect their liver. And that's non-negotiable. And so we're decreasing their immune system, and this does leave the recipient of the transplant open to a number of infections. So, for example, right at the time of surgery, they often get IV antibiotics to prevent infection. Sometimes they'll get IV anti-fungus drugs to prevent fungus infection. And then we know that there's a handful of infections that they're at risk for in the first several months to a year after transplant that we just have drugs that are very good at preventing, and so we give them. The types of infections we're trying to prevent are one type of lung infection called pneumocystis pneumonia, and we use a drug called Bactrim for that very commonly. Another type of infection, that box that you held up, the Valcyte box, the intention of that is to prevent a very, very common viral infection called cytomegalovirus, and it's an excellent drug, and so we use it. And then finally, we almost always, at the very beginning after transplant, worry about fungus infections, especially in the mouth or the throat. And so most patients right after transplant will get an anti-fungus drug. Usually it's a swish and swallow sort of medicine, but some patients do go on a pill called fluconazole, just as you mentioned.
Let me ask you something. In comparison to what David said at the beginning, how long are the parents expect to be using the prophylaxis drugs?
The good news about prophylaxis is in almost everybody, it's just a short-term plan, because the time when the infections are most common is typically in the months and weeks right after transplant. So, for example, every center has a different regimen, but the prevention for the lung infection is often on the order of 6 months to a year. The virus infection is often on the order of 3 to 6 months. The fungus, it may just be a few weeks.
Okay. So maybe this will allow the parents to understand that at the beginning they will go home with a newly transplanted child and with a big box of medications. But then later on, a lot of them will be DC, and they will pretty much maybe stay in one immunosuppressant and maybe some other drug for one of the side effects. So the idea is that they will be decreasing the usage of different drugs.
Right, and we always reassure our patients about this. It's a lot to keep track of at the beginning, but it will get better and better typically as the months go on. And like you say, many patients with liver transplants, by the time they're a couple years out from transplant, will find themselves on one drug only. Maybe, like you said, another one to control a side effect here and there.
Perfect. So I just want to maybe finish with one topic that is, we could be talking about this for a week, but it's something that will happen. Even regardless of the fact that the parents will give the drug at exactly the same time, or that time in life that we're all been when we go from childhood to adulthood, that that we're in our late teens and we don't want to take the drug and we lie about taking the drug, which is rejection. So rejection will happen in a predicted amount of patients. So what do you usually do when a patient has rejection? What's usually the treatment so the parents will understand what's going to be, what should they be expecting?
Yeah, so I agree with your point that the rejection is the attack of the immune system on the liver, and it's a very common thing. It's a bump in the road that a lot of transplant recipients have to cross. When the rejection is very mild, it's possible in some cases to handle it with smaller doses of steroids, and then even just an increase in the general plan for immunosuppression, the pills that you take every day to keep the immune system under control. Sometimes the rejection is a little more serious and we ask the patient to come into the hospital, and in those cases often we give much larger doses of steroids, very similar to the prednisone that we talked about earlier, and those are often given in IV form. So this would require a short inpatient stay, and then only very rarely do we have to bring out the bigger guns and use even stronger immunosuppressant medications than the steroids. Steroids often handle it.
Maybe I also want to stress out that the success nowadays of treating rejection is really high. So we have some tools that will help us to recover the liver and in a while go back to normal track. So I really want to thank you for sharing with us this type of information because when the time finally comes for the parents that they're getting ready for transplantation, this that we have spoken about today, it's key because it's, as David mentioned at the beginning, it's going to happen for the rest of their life. And then it's going to be the only tool that they will have at home to keep the liver working properly and having a safe recovery. So I will leave you guys with some comments that you might want to share with the audience to close in.
Oh yeah, I just want to say that I've been doing this now for 12 years, and I'm always just really happy to see how well my patients do after transplant. Seeing them in clinic is one of the happiest possible things because their lives literally turn around, and it may seem a little bit intimidating at the beginning, but it's very, very manageable, and people do great after liver transplant.
Yeah, that's good. David, you want to mention anything?
Yeah, I think to kind of echo what Mia said, I totally agree. It's always amazing to see how the patients recover after transplant, just kind of see their growth and familiarity. The one thing I did want to add, I think you already stressed this earlier, is these are great medicines to help protect the liver against rejection, against the immune system attacking it. But really important you come to clinic, get the lab draws as appropriate, because it's really important we do it safely as well.
Okay, I think that's those are key points that we need to really stress very clearly every time we see the patient. So I want to thank you guys. I want to thank the University of Illinois Chicago. I want to thank the College of Pharmacy for this time, and I look forward to another later program that we can share more topics regarding all the pharmacy that is behind the liver transplant, that it works in the favor of the patient. Thank you so much.
De esta manera, conclusión a nuestro nuevo webinar, en el cual tuvimos la valiosa participación del equipo de la Escuela de Farmacia de la Universidad de Illinois en Chicago, quienes son unos verdaderos especialistas en el manejo de los inmunosupresores y todas las drogas que nuestros pacientes trasplantados necesitan para poder mantener un trasplante sano y tener una sobrevida adecuada. Espero que lo disfruten y, como siempre, los invito a enviar sus comentarios y a seguirnos en todas nuestras redes. Fundahigado América en Facebook, en Instagram y en Twitter. Muchas gracias y disfruten.